Thank you, Chairman. My name is Masaki Ieda from University of Tsukuba, Japan. Today I'm going to talk about cardiac reprogramming and regeneration. There is no business related to COI that should be disclosed in this presentation. So first, I'd like to talk about the background of heart failure. So there is a high demand for the treatment of heart failure. Heart disease, including heart failure, is a leading cause of death. Heart failure patients are dramatically increasing worldwide, and heart transplantation is insufficient due to the limited donors. So we definitely need new therapy for the treatment of heart failure. The lower circle indicates causes of mortality in Japan, and the heart disease is the second killer in Japan, and mortality due to heart disease is more than 200,000 per year. So which show high demand of the new treatment of heart failure. Next, I'd like to talk about how we can regenerate heart. And first, I'd like to explain about Ips cells. As you may know, we can generate pluripotent stem cells called induced pluripotent stem cell, IPS, from fibroblast by using Yamanaka 4 factors, OCT4, SOX2, KLF4, and c-MYC. Ips cells, which are stem cells, can differentiate into any type of cells, including cardiac muscle cells, neurons, blood, and livers. And we can use cardiomyocytes for cell therapy. However, there is a risk of tumor formation if you transplant immature pluripotent stem cells in the heart, as you can see in the lower panel. So we have to be careful to inject cardiomyocytes and stem cells into the heart. Next, I'd like to talk about cardiac reprogramming. So the left panel shows a normal heart, and the green cells indicate cardiac fibroblasts, and the red cells indicate cardiac muscle cells. As you may see, there are a lot of cardiac fibroblasts in the normal heart. In the right panel, you can see myocardial infarction. So compared with normal heart, after myocardial infarction, cardiomyocytes cannot regenerate, and the lost tissue is replaced by fibrosis, which include fibroblasts and extracellular matrix. Since after myocardial infarction, cardiac function decline, leading to heart failure and cardiac death. So we need heart regeneration. So in our strategy, if we can reprogram fibroblasts directly into cardiomyocytes, maybe we can repair infarct heart. So cardiac reprogramming may regenerate infarct heart. Next, I'd like to talk about how we can generate cardiac myocytes from fibroblast. First, this panel shows using Ips cells. Fibroblasts can be converted into Ips cells by using stem cell specific factors called Yamanaka 4 factors, OCT4, SOX2, KLF4, and c-MYC. And the Ips cells can differentiate into any type of cells, but you must purify cardiomyocytes before transplantation. Otherwise, you can make tumor in the heart. In contrast, our strategy is direct cardiac reprogramming, shown in the lower panel. In this case, we found that overexpression of cardiac-specific factors, GATA4, MEF2C, and TBX5 into the fibroblast, the fibroblast directly transdifferentiate into cardiac muscle cells without without mediating through Ips cells. This is called direct cardiac reprogramming, or in short, cardiac reprogramming. The generated cardiomyocytes are now called induced cardiomyocytes, or ICMs. So we found that in 2010, GATA4, MEF2C, and TBX5, in short GMT, are cardiac reprogramming factors in vitro. How we can regenerate heart in human? First, I'd like to talk about Ips cell derived cardiomyocytes. So here is in the left panel, you can see the patients, heart disease patients. He has heart attack, and there is a lot of cardiac fibroblasts in the infarct area. If you use iPS cells, first you have to make iPS cells from the patient. First, you take cells from the patient, culture and expand the cells, and generate iPS cells by using MRK4 factors, and differentiate into cardiomyocytes. You must purify cardiomyocytes by maybe using FACS, and then transplant the cardiomyocytes via open heart surgery, as shown in this panel. This is quite promising strategy, but there are several issues before clinical applications. First, number one, this is complicated and long process. And also, as I show, there is a possibility of making tumor by iPS cell contamination. Third, poor survival of the transplanted cardiac muscle cells, because cardiomyocytes need a lot of nutrients and oxygen, so the environment might be not good for cell survival. And also, you need open heart surgery for transplant a lot of cardiomyocytes in the heart. In contrast, our strategy is using cardiac reprogramming to regenerate heart, as shown in the lower panel. In this case, you just need to transduce overexpress cardiac reprogramming factors into the resident cardiac fibroblast, and then convert these fibroblasts directly into cardiomyocytes in situ within the heart. So you don't need cell transplantation anymore. So you can skip long process of making cardiomyocytes in the middle, and this is good because this strategy is simple and fast. And second, no risk of tumor formation because you don't use iPS cells. And third, maybe this is an anti-fibrotic therapy for not only for cardiac regeneration, but this can have an anti-fibrotic therapy. So this is a good and promising strategy for cardiac regeneration. So today I'd like to talk about two stories. First, we found that diclofenac, which is an anti-inflammatory drug, improved cardiac reprogramming in vitro. We found that GATA4, MEF2C, and TBX5 and addition of diclofenac greatly improved cardiac reprogramming from fibroblasts, which was published in 2019. We also found that in vivo cardiac reprogramming could repair infarct heart in mouse. So I'd like to talk about, from the beginning, diclofenac story. Here is a first paper which was published in 2010 in Cell. We found that overexpression of GATA4, MEF2C, and TBX5 into the fibroblast can generate cardiomyocytes in vitro. So the left panel indicates fibroblasts, and the right panel indicates cardiac muscle cells. And as you can see here, the cardiomyocytes beat spontaneously. Next, I'd like to talk about the problem of cardiac reprogramming in vitro. We previously found that GATA4, MEF2C, and TBX5 and addition of HAN2 greatly improve cardiac reprogramming in embryonic fibroblasts, as shown in the upper panel. However, we realized that overexpression of GHMT can reprogram aged fibroblasts into the cardiomyocytes, but the reprogramming efficiency was low, and the mechanism of the difference between embryo and aged fibroblasts remain unknown. So we want to make more cardiac muscle cells in aged fibroblasts. To test this, we screened chemicals to improve cardiac reprogramming in aged fibroblasts. To test this, we use chemical library screening, as shown in the left panel. We overexpress GHMT into the mouse fibroblasts, which come from alpha-myosin heavy chain GFP transgenic mouse, in which only cardiomyocytes express GFP. We spread these fibroblasts into the 96 well plates and overexpressed GHMT, and we added chemicals individually one by one into the well. and we screened more than 8,400 compounds first, and by first screening we found 37 compounds could improve cardiac reprogramming by cell image analyzer. And after second round we found that 4 compounds can maximally improve cardiac reprogramming in fibroblasts. And one of them is a diclofenac. So as you can see in the lower panel, we found that addition of diclofenac into GHMT overexpression could greatly improve cardiac reprogramming in aged cardiac fibroblasts. And more interestingly, we found that this effect of diclofenac is only in aged fibroblasts, but not shown in embryonic fibroblasts. So suggesting diclofenac effect is very age-dependent, age-specific effect, which is very curious. So what is diclofenac? So this diclofenac is called, in other name, Voltaren. So diclofenac is an FDA-approved anti-inflammatory drug, and diclofenac inhibit COX-1 and 2 and block prostaglandin synthesis and inhibit inflammation. So this is sold worldwide, and which is very safe drug. However, we first didn't know why diclofenac could improve cardiac reprogramming in vitro. So to test the reason of the effect of diclofenac, we analyzed the difference between embryo, neonate, and aged fibroblast, as you can see here. So the white bar indicates embryonic fibroblast, the green bar indicates neonate fibroblast, and the red bar indicates aged fibroblast, and black ones are cardiac muscle cells. As you can see here in the left panels, COX-1, COX-2, EP4, prostaglandin receptor, and interleukin-1 receptors are greatly upregulated in aged fibroblasts compared with embryonic fibroblasts, suggesting inflammatory genes were upregulated with aging. In the right panel, the fibroblast markers, periostin, Cy1, are also increased in aged fibroblasts compared with embryonic fibroblasts, so suggesting fibrosis genes are upregulated with aging. So these results suggested that inflammation and fibroblast-related genes were upregulated in the aged fibroblasts compared with embryos. So in summary, we found that in aged fibroblasts, there is a signaling cascade. So in aged fibroblasts, COX-2, prostaglandin, interleukin, such kind of inflammatory genes were upregulated, which lead to fibrotic gene upregulation and inhibit cardiac reprogramming. However, if we inhibit COX-2 expression by diclofenac, we can suppress inflammation and fibrosis in aged fibroblasts, and then we can generate more cardiac muscle cells by GHMT. So diclofenac promoted cardiac reprogramming via suppression of inflammation and fibrosis. So which is very interesting and curious for cardiac regeneration, but also we can understand what is aging, what's the difference between young and age. So such kind of issue is very important, I think, worldwide, and important issues. So I think it's a very interesting story. So now I finished talking about the first story, and next I'd like to move on to the next in vivo cardiac reprogramming. So first we tested Sendai virus vector expressing GATA4, MEF2-3, and TBX5 in short SEV-GMT in mouse infarct heart. In this experiment, we used TCF21 ICRI tomato mouse, which can trace fibroblast lineaging. As you can see here, only cardiac fibroblasts express tomato in this mouse, and after overexpression of GMT by Sendai virus vectors, fibroblasts can be reprogrammed into ICMs in vivo or not. We test this. And this is immunohistochemistry in mouse heart after one month of MI, and we found that tomato positive cells express cardiac troponin T, suggesting this cells is ICM regenerated from cardiac fibroblasts. And we calculated the efficiency of in vivo cardiac reprogramming, and we found that around 5% of fibroblasts can be reprogrammed into ICMs in vivo by overexpression of SEV-GMT. So GMT could reprogram cardiac fibroblasts into cardiomyocytes in vivo. Next, we tested cardiac echo to test the function after MI. So this is mouse cardiac echo. As you may know, we can check cardiac function very easily using echo as human. And this is M-mode imaging, and we found that fractional shortening, which is similar to ejection fraction, is also increased by Sendai-Wallace GMT overexpression compared with negative control. So these results suggested that GMT could improve cardiac function after MI. Next, we analyze the ozone staining to check the fibrotic area. So the left panel indicates sham, and the right slice indicates GMT expression. And if we compare the middle lane plane L2, we found that the blue area, which is a fibrotic area, greatly reduced by overexpression of GMT. The right graphs indicate the quantitative data of fibrosis in control, PMX GMT, and Sendai-Wallace GMT. Sendai-Wallace GMT is red. As you can see here, Sendai-Wallace GMT greatly reduced fibrosis after MI. So these results suggested that GMT gene delivery could repair, in fact, heart in mouse model. So which was published in Cell Stem Cell previously. Next we wondered, is it truly cardiac reprogramming, or maybe cell fusion between cardiac fibroblasts and cardiomyocytes may occur, and which may mimic cardiac reprogramming or cardiac regeneration. To clarify whether this is truly cardiac reprogramming or cell fusion in vivo, we next use TCF21I3 MTMG mouse to check fibroblast cell fusion. In this mouse, in contrast to tomato mouse, tomato and GFP mixed Flox mouse was used. So by crossing this mouse with TCF21I3 mouse, we can, in this mouse, only fibroblasts express GFP and cardiomyocytes express tomato. And if cardiac reprogramming can happen, cardiomyocytes should express only GFP. But if cardiac fibroblasts self-fuse with endogenous resident cardiomyocytes, they should become yellow cardiomyocytes because they express GFP and tomato. So this indicates self-fusion. So this is a first study to demonstrate whether in vivo cardiac reprogramming is truly cardiac reprogramming or self-fusion. And we checked this, and we found that almost 80% of the regenerated new muscle cells are due to bona fide cardiac reprogramming. So as you can see in the left panels, the green cells did not express tomato, and the lower panel is the same. So these results indicated that overexpression of GMT generate cardiac myocytes mainly via cardiac reprogramming. So this is the right panel indicates the quantitative data of cardiac reprogramming and cell fusion, and we found that around 70% of the cells are bona fide cardiac reprogramming. So this was published this year in Circulation. So we now confirm that we can generate new muscle cells from cardiac reprogramming. So today I talk about two stories. First, diclofenac improved cardiac reprogramming, and next I talk about in vivo cardiac reprogramming could repair infarct heart via bona fide cardiac reprogramming. So here, this is still a dream of us. We like to translate this technology into the human. However, we still need to make a lot of effort to make this dream come true. Lastly, I'd like to acknowledge members in the University of Tsukuba, and this is here is a picture of the Department of Cardiology in University of Tsukuba, and yeah, I'd like to acknowledge them, and thank you for your attention.